So we are beginning this session with page number 144 of therapeutic guidelines. And this describes temporomandibular disorders. And we are still following orofacial pain chapter. Now, temporomandibular disorders is a collective term for a number of clinical problems that involve the masticatory muscles or temporomandibular joints and associated structures. So it is muscle, joint, and associated structures like disc. They can be classified into subtypes such as temporomandibular joint disorders and masticatory muscle disorders. Now we have accurate diagnosis of the temporomandibular disorder requires appropriate history.
Ma'am,
Yeah.
ma'am, I can't see the slides. I can only see you have opened the document.
Okay, just a minute then.
I mean the folder, only the folder.
Now?
No, ma'am. Okay, now can.
Okay.
Yes.
So we have, temporomandibular disorders, a collective term divided into joint disorder and masticatory muscle disorder. It is a combination, it can be a combination of both. And associated structure, we can include disc, interarticular disc for that. And accurate diagnosis requires proper history, examination, and imaging. Table 15 below outlines signs and symptoms of temporomandibular disorders. The commonest symptoms are pain and restriction with the mandibular function. Pain is usually experienced in and around the ears. This region will be sore, okay? And masticatory muscles, which would be temporalis, sometimes the insertion of lateral pterygoid, medial pterygoid, and masseter, that soreness over basically preauricular region and cheek region. Headache, pain, neck pain. This is the temporalis insertion into this above the. That's why headache is a jointly associated symptom. Neck pain, limited jaw opening, joint sounds, and clenching of teeth. So uncommon symptoms being reduced hearing, changes in occlusion, toothache, and altered sensation in the face, paresthesia, a feeling of swelling. Then we have signs, tenderness of the TM joints and masticatory muscles during movement. Temporomandibular joint sounds, clicking, clunking, or crepitus during repetitive opening and closing of the mouth, as well as lateral and protrusive movements. So symptoms are what the patient experiences and signs which can be elicited by the dentist. So this is when dentist is doing the palpation, that time it is tender. So that's different from pain experience. And clicking, clunking, crepitus sounds, which can be heard by an external person. Sometimes a patient can hear their own crepitus or clicking sounds. So, or heard by another person. Then deviation, this is the frank deviation or opening of the jaw. We check with the midline deviating when the patient is biting. Then an important note here is all temporomandibular joint sounds are not an indication for treatment unless they are associated with pain or dysfunction. So a patient having just the clicks without any pain or dysfunction, we need not treat that patient. Risk factors for TMJ disorders include direct trauma or indirect trauma. Example, acceleration, deceleration injury. And parafunctional activities like tooth grinding or clenching teeth. So constant grinding, parafunctional habit, is one of the commonest cause of temporomandibular dysfunction syndrome. Psychosocial issues, example, stress, anxiety. Again, TMJ disorders can happen. They may contribute to development of TMDs. Malocclusion has not been shown to be a risk factor for temporomandibular disorders. So malocclusion is out of purview. It's usually psychosocial and parafunctional habits. Then habits such as lip and cheek biting, biting fingernails, chewing gum, smoking can perpetuate an existing temporomandibular disorder. So bruxism habit has a direct primary effect, whereas cheek biting, fingernail biting, chewing gum and all, they have a secondary enhancing effect. And we have chronic temporomandibular disorders are often associated with psychological disorders. Management of TMDs, the aim of this temporomandibular disorder management is to control the patient's symptoms rather than achieve a cure. So cure is by treating the cause, which is the psychosocial disorder or a habit. That is the definitive cure. What first aim would be here to control the symptoms. Treatment goals should be tailored to the specific diagnosis and may include reducing pain and adverse loading, restoring mandibular function, and resuming normal daily activities. So we are first going towards symptomatic relief so that the patient is first restored and rehabilitated to the normal functioning of the joint. Management strategies as a general dentist are conservative and can include patient education and reassurance, jaw rest. So in fact, we advise, okay, that's coming as a next point, jaw rest, which is using strategies such as dietary modification to minimize chewing. They shouldn't be eating hard foods. They shouldn't be eating very chewy foods, which needs a lot of efforts in chewing. And that is eating only soft foods. Then avoidance of extreme jaw movements. So it is particularly advised to be to these patients to be very cautious while yawning. In fact, they can support their mandible whenever they are feeling like yawning. If initially it is a very reflexive exercise, but once one is educated and they start being aware about it, it is possible. Yawning is contrary to sneezing. It sets in a slow pace rather than a fast reflexive action. Then avoidance of chewing gum, strict no to chewing gum because it's not usually a dependency. And singing. Massage and application of warm packs to the TM joints and cheeks several times a day. Cold packs can be useful in the presence of redness and swelling. Once we want to control the inflammation, that time cold packs are good. Then behavioral modification by identifying managing source of stress, which may be facilitated by individual or group counseling. And regular treatment, gentle muscle stretching and massaging by a physiotherapist familiar in the management of temporomandibular disorders. And then we have use of custom-made full coverage intraoral occlusal splints to reduce joint loading, muscle activity and pain. Splints are generally worn at night and protect teeth from effects of bruxism. They should constitute only one part of the broader management approach. So we have all this, the splints are basically protection in the night. Okay. Then we have short-term use of drugs. We usually discourage patients relying on use of drugs alone because they would be usually, particularly the drugs of dependence are used to treat acute symptoms of temporomandibular disorders because of their chronic nature. They are not core dental pain like pain, which can be controlled by NSAIDs. So usually TMDs will be given chronic painkillers, and they have tendency to make the patient dependent. Analgesics, muscle relaxants, anxiolytics, anticonvulsants. Here we have anxiolytics and anticonvulsants for the patients who are anxious and who are having secondary TMJ disorders to their psychosomatic disorder. Then corticosteroids for reducing inflammation in the joint, and antidepressants have been used with variable success. So they are talking of the range of patients who are having manifestation of temporomandibular disorder as a secondary or primary to psychosomatic disorder. An acute exacerbation of chronic temporomandibular disorder can be treated with ibuprofen or paracetamol. And if conservative measures are inadequate and pain and dysfunction becomes severe or chronic, refer the patient to oral medicine specialist or oral and maxillofacial surgeon. So our area is very conservative. We are only doing education, reassurance, splints, and giving instructions on reducing jaw movements. And short-term drugs can be given like NSAIDs, ibuprofen or paracetamol. After this also, if it is not getting managed, referral. There is some evidence of using botulinum toxin to manage the symptoms of TMDs when conservative measures are inadequate, but this would be done by the specialist. Ensure patients understand that botulinum toxin is not a cure for the disorders, but may be used as a part of overall management strategy. The use of botulinum toxin for temporomandibular disorders is off-label. If recommended doses and protocols are adhered to, incidence of adverse effects is low. Local complications include stinging during injections, bruising at the site of injection, and excessive muscle weakness. So adverse effects associated with injection of botulinum toxin into non-target tissues are rare, but can include alteration in smile and temporary dry mouth. And systemic adverse effects include influenza-like syndrome, that is transient, and hypersensitivity. Reactions can happen with this botulinum toxin. Surgery for these disorders is rarely required. Only consider referring the patient for surgical assessment if symptoms have not responded to conservative management and there is definitive evidence of internal joint derangement, which is they are talking of the disc, or joint pathology on imaging. So internal joint derangement means disc has permanently changed its position and it is not going back or going back with an interruption which is not manageable without surgical intervention. Then only we consider surgery and assessments. And it should be visible joint pathology on imaging. Then only we refer to surgeon. Otherwise, oral medicine specialist is the first area we refer to. So this completes TMJ. If you have any doubts.